Hi, it's Dr. Centeno, and thanks for joining me today. We've got an interesting topic. We're going to talk about the idea of using ultrasound in order to measure intracranial hypertension. And this came up because I've had a bunch of patients who have come to me to treat their craniocervical instability, who had some tests done at another clinic using ultrasound, and in this case, ultrasound over the eye. And they wanted me to read and interpret those tests because those tests showed that they had intracranial hypertension. So this is one of those tests that I frequently receive. So I'd like to go through the science behind what all of this means. And then also go over whether or not this really changes the treatment plan for someone with craniocervical instability. So a lot to cover here today. Yeah, let's see here. I've got someone telling me they can't see me. Hopefully you all can see me. I will reduce some bandwidth on my end just in case that's a potential issue. So let me make some changes here. Hopefully. Okay. Looks like that got fixed. So let me share my screen and I'll get started. Again, you can ask questions about this topic. You can ask questions about any topic, not just this topic. And again, today we're going to talk about the use of ultrasound to diagnose intracranial hypertension. So let me get into it here. Let me share my screen. And it looks like that worked. And we'll get into the presentation. Okay, so the title of today's presentation is What's the Deal with Optic Nerve Ultrasound and Intracranial Hypertension? And again, this got started because I had patients showing up with these reports from another clinic stating that this or that test showed that they had intracranial hypertension. And so this is part of a series where I'm sort of diving into these different tests and trying to look at what the claim is versus the research that's published out there, and whether or not these tests might be helpful in patients with craniocervical instability, or are they a waste of money? Let's try to figure this out. So what is intracranial hypertension? It's pretty simply increased pressure within the cerebrospinal fluid, and that's the fluid that surrounds the brain. And this is often felt by patients as a pressure headache, although there are lots and lots of causes of pressure headache that have nothing to do with intracranial hypertension. But that's the general idea, is that the inside increased pressure in the skull, in that cerebrospinal fluid, is causing symptoms for the patient. So let's look at the anatomy of intracranial hypertension and craniocervical instability. And let me grab a pen here. So we have C1, C2 here from the front, and you can see that we have the internal jugular vein, which I'll highlight here, that lives right in front of, if we look at from the side here, C1 and C2. So if we have C1 and C2 rotation, we could certainly see that C1 and C2 could put some pressure on the internal jugular vein. Now realize this is one of the routes that blood gets out of the brain. So we could see some increased pressure back up if there's pressure on this internal jugular vein. And we also see that the styloid is out here, and it's usually got a ligament attached to it. And the concept would be that could make things worse if there is pressure from the front and an elongated styloid. We may see more internal jugular vein compression. And this is the view from above. So again, we've got the jugular vein shown here, jugular vein shown here, And then obviously we see C1 there. So for example, we know that this transverse band of the cruciate ligament or transverse ligament is something that helps to stabilize this area. And if perhaps there was some laxity there or in the alar ligament, which is here, that we may see too much rotation or movement of C1. And same thing here. This is more of a cross-section from above, just sort of making it all look very simple. Now, one of the things I always say, and we have to be careful of, is we need to be careful because there's a lot of people walking around with internal jugular vein compression. Somewhere between 1 in 3 and 1 in 4 adults that get imaging of their head and neck have internal jugular vein compression and don't really know about it. But if we see C1, C2 rotation or excessive rotation, again, we can get that internal jugular vein compression. So what are the symptoms of internal jugular vein compression? Well, this is from a study where they took patients with internal jugular vein stenosis, where they were convinced that their internal jugular vein was causing their symptoms. And if we put that in a word cloud, what we tend to see are a bunch of different symptoms. Obviously, there's a lot of causes for headache, a lot of causes for neck pain, a lot of causes for hearing impairment, a lot of causes for insomnia. But these two symptoms seem to be prevalent and where there are not as many other causes. So head noises, tinnitus would seem to be things that are more specific for, again, they don't cinch the diagnosis, internal jugular vein compression, again, leading to increased pressure in the head or intracranial hypertension. So if someone walks in with a pressure headache, as you saw, it wasn't even high on the list of symptoms for internal jugular vein compression, but let's say they've got pressure headache and tinnitus, and they have a diagnosis of CCI. Can we use optic nerve ultrasound to diagnose increased intracranial hypertension or increased intracranial pressure in the head? So this is a diagram of what this looks like. You see an ultrasound probe over here. You basically stick it on the eye, and the ultrasound probe looks down this way. Now, the ultrasound probe is only going to be able to see this portion of the optic nerve. The rest of the optic nerve here is going to be encased in bone, so ultrasound is not going to see that well. And this is what it looks like. This is the eye up here, or the globe of the eye. And we see this area here, which is the optic nerve sheath. And we can get a diameter on that sheath right here at the base. And that's this D2. So those are the same things there. And off to the right, this is all cleaned up, so it looks a little better and easier to interpret, but that's the idea. And the concept is that if you've got fluid backup, that fluid is going to back up from the rest of the brain. So that increased intracranial pressure is going to back up to the rest of the brain, and it's going to expand the size of the base of the optic nerve here. And we're going to be able to pick that up on ultrasound. So in this case here, they're measuring 3 millimeters below the retina here, and then they're taking their measurement at that spot, which seems to be not hard to do. Listen, it's not rocket science to put an ultrasound probe on someone's eye and take this measurement, but the question is, what does it show you? So can optic nerve sheath diameter, and that's something called ONSD, optic nerve sheath diameter, detect intracranial hypertension in patients with CCI and headache? Now, I've done this for lots of different tests. And one of the things you probably learned so far is you need to have, in order to make that, you need to have patients who have the disease, right? Patients with that we know have increased intracranial pressure and craniocervical instability, that being measured by a catheter that's fed up from the low back into the brain to measure that, not just opening pressure on a lumbar puncture. And then a normal control group of people at a similar age, sex, et cetera, who have no problems at all. And we need to see a big difference between those two groups. So what do we know about this measurement? Well, we know that if we take patients in the neurosurgical ICU who are suspected of having increased pressure in their head or intracranial hypertension, that in this one study, if this diameter was more than 5 or equal to 5 millimeters, that was correlated with the most severely brain injured patients in a coma. Correlated well with CAT scan, but we don't even have a control group here, meaning they didn't take all the nurses and doctors and measure their ONSD. So we don't really know what that means. In addition, these are severely injured people in comas. And the bigger their diameter, meaning the higher the intracranial hypertension was, the more deep their coma was. That's this low Glasgow Coma Scale, or GCS. So this one's not all that helpful for our purposes. Again, here's another one, patients in the ICU. And here it was 5.7. So at least here they did measure intracranial pressure. And they found the good news was that no patient under a 5.7 millimeter diameter had elevated intracranial pressure. So that's better, but there's still no control group. We don't know what the diameters of the doctors or nurses were, what their optic nerve sheath diameters were, patients or people who were caring for these patients, meaning people without any problems. What is their diameter? We know, however, that ONSD is increased in patients with high blood pressure. It tends to be patients with the higher end of high blood pressure. So that's a problem, right? If you just have high blood pressure, it means we really can't trust this measurement. And this is an interesting study. This one looked at patients with headaches while upright who had a CSF leak. So this is a little bit like some of our patients with CCI, and the patients without orthostatic headache, meaning these are people who had headache when they went to stand up. They had an ONSD of 5.48, which was similar to patients with orthostatic headache. So that doesn't help us. But that was measured when they were lying supine. And if we then went from supine to standing, we did see a difference between these two groups. And that was about a 1 millimeter difference. So this is interesting. It maybe shows that in someone where you suspect a CSF leak, you could take this measurement with them lying supine and standing and try to get a sense of whether or not there's a difference there that goes below the published values within this study. And this is another interesting one, a little bit like our CCI group, again, not the same, but a little bit like. These are patients with a mild traumatic brain injury. And these are patients where they took baseline measurements. So this is the kind of stuff we're getting from these clinics, right? And as you can see, with just baseline diameter measurements, lying supine, these two data sets are identical, meaning the patients who didn't have TBI had the same measurements as the patients who did have TBI. Now, if we ask them to do a Valsalva, and that's where they bear down really hard, these two things did separate out finally. So we saw that the folks with no TBI, there was really no difference in their nerve sheath diameter, and the patients with TBI, there was a difference when they Valsalva. So maybe this is something that could be used as well. So now we've got supine and standing measurements, but that kind of links more to a CSF leak, not most of our CCI patients. Here we have the idea of having them do this Valsalva maneuver, and maybe that helps. But again, these aren't CCI patients. These are mild traumatic brain injury patients. So in conclusion, you can use this in the neurosurgical ICU to determine who's got intracranial hypertension, but that's more related to the depth of their coma. There are measurements that you can use for that. That's a typo there, so I apologize. We know that this measurement is increased in high blood pressure patients, and we know that a drop in this measurement when going from supine to upright may indicate a CSF leak. We have a single study on that, so I would say it's kind of interesting. We know that a Valsalva maneuver may be able to identify MTBI patients, but the problem is there's zero published data on CCI patients with pressure headache. So that's the concern, right? Is that we have clinics that are using this as some sort of proof that someone in this category, meaning a CCI patient, has intracranial hypertension, but we don't really have the data to support that conclusion. So you have to ask yourself, is it worth paying for a suite of tests that have never been published on CCI patients to diagnose intracranial hypertension? And the first thing I always tell patients is, will it change the treatment plan? That's a big one, right? We should never do any diagnostic tests that won't change the treatment plan. And usually the answer is it's not going to change the treatment plan. We're still going to try to get rid of their instability through injection or surgery. So we're not really changing the treatment plan by knowing this. And listen, if you want us to measure your ONSD, we're happy to do that at no charge and tell you what we see. But what the number is and what it means is still pretty much open to interpretation after a deep dive into this literature. So let me go ahead and I'll stop sharing here and we'll see if we've got any questions that we can answer. Let me go here. Looks like we have a few of them. So Andy, just letting you know that your former PT, Jim Elliott, yep, Jim's a great guy, has shown that a structured neck strengthening program can reverse fatty infiltration atrophy in the multifidus longus coili and longus capitis. That's great to see, Andy. I don't know if I saw that one or not, so send that one to me. I think you guys have my email address, so let me check that out, and I'd be happy to look at that. Andy, can atrophy the trapezius, splenius, semispinalis capitis muscles that overlay the suboccipital muscles cause the head to feel heavy? That's a good question. I don't know. I know the answer to that one. Jim, if you're referring to that research, looked at the deep segmental stabilizers. I think in various studies he added the splenius, semispinalis capitis in there or didn't. But as far as the perception of head heaviness, that would be mostly the segmental muscles there. So those suboccipital muscles, rectus, capitis, posterior major, the obliques, etc. Andy, have you ever had an EDS patient with mild to moderate CCI who didn't complain of their head feeling heavy? It's a common complaint of all CCI patients, not only EDS. So a pretty frequent complaint. I never say never in medicine, so I'm sure I've had lots of CCI patients who don't have a heavy head feeling, but it's pretty common. Tony, hello, Dr. Centeno. You previously spoke about adjacent segment disease occurring after disc replacement fusion. To your knowledge, have there been any studies, clinical trials, in the occurrence of ASD in patients that get regular PRP, BMC, prolotherapy injections after the fusion disc replacement? So do patients experience less AST? Tony, no one has done that study of which I'm aware of, but that would be a good one to do. The biggest problem with doing it always comes down to trying to separate two different groups, one who are getting the treatment and a similar group who are not being treated over a long period of time. And the problem with that is you're going to have a lot of treatment happening in patients with chronic neck pain. And so it's really hard study to do because you have to ask a group of patients to get no treatment at all for quite some time. And that's hard. It's a hard thing to do to somebody. So it's probably would be a hard one to get done practically. Centeno-Schultz Clinic, been advanced by DB, where the symptoms of ICH was told that was my issue, but the real issue is CCI. Yeah, so I showed intrajugular vein compression, which would be similar symptoms. But, in intracranial hypertension can also have a pressure headache. As I said before, the problem is lots of other things cause pressure headache. Dr. P, do you think that joint hypermobility syndrome patients have less fragility in their ligaments and better joint control compared to EDS HT patients? It's a good question. I don't know the answer to that one. Eric, what if a person has a fusion at 1-2? Is it contraindicated to use ultrasound for diagnosing hypertension in this circumstance? I don't think it would make too much of a difference. We're really from the front there not going to see the fusion at all. So I don't think it's going to change the imaging. Now, could it change the result? It could. That could be a wild card that we don't know about, meaning do patients who have had a 1-2 fusion end up with increased diameters just because they have the fusion? I don't know the answer to that. I don't think anyone does. Jason, can having the brainstem mashed in by CCI lead to a release of stress hormones like adrenaline? Can those stress hormones cover up pain, halt inflammation, neurologic symptoms associated with CCI? I find that if I'm too active, I will initially feel awful, but fairly quickly I reach a point where I no longer sense any hint of CCI symptoms. No pain or anything. Typically lose the ability to sleep and heart rate goes up. Sometimes hit me brick wall 12 to 24 hours later. Well, I think it's more probably irritation of the vagus nerve that's leading to a decrease of the brakes on the heart and that fight or flight stress reaction more than the brainstem getting mashed. But listen, at the end of the day, I think what you're describing is possibly craniocervical instability with autonomic symptoms. Andy, for neck training, if I'm correct, exercises that are meant to induce hypertrophy should be done every day to allow healing. Motor control purposes, laser trusting should be done every day. Ideally, as long as you can tolerate it, meaning that one of the problems with the active physical therapy paradigm is that there isn't oftentimes a lot of respect for threading the needle with the patient. And what I mean by threading the needle with the patient is stressing apart enough so that the muscles can either maintain themselves or get stronger, but not pushing the patient over the edge and causing a huge flare-up. We know that huge flare-ups cause inhibition of the nerves that supply the muscles. So our goal is to thread that needle, kind of walk that fine line between stressing the part enough so that it can maintain or get stronger, but not overstressing it so that we shut down the muscles due to a huge flare-up. CSC has been advanced by Sherry Scott. Because of my headaches, intracranial hypertension was suggested. The headaches also being caused by CCI. How can you be sure which is causing the headaches? Yeah, Sherry, that's a good question. I mean, the good news is that we can do things like diagnostically block the upper neck joints, the nerves that cause headaches, and if that diagnostic block takes the headache away, we know it's not intracranial hypertension. So we can usually do it from that side. Jason, why do some people tolerate vein compression better than others? Well, Jason, I think we need to be careful here, right? We're saying that intrajugular vein compression on something like a CT venogram is causing headaches, for example, in people, but we don't have that data, meaning that I can't test that hypothesis. It's also equally likely that the patients we're seeing with compressed internal jugular veins, we're actually treating normal variants. And in fact, that's not the cause at all of any of their symptoms. So we need to be really careful. It's also possible that some people tolerate vein compression better than others, perhaps due to collaterals that they have, meaning collateral veins. But we need to be careful because we don't really know scientifically that internal jugular vein compression is causing a lot of symptoms because it's so common in patients without symptoms. Again, 1 in 3 to 1 in 5 patients walking around out there who gets their neck imaged has internal jugular vein compression and no symptoms at all. That's everything from moderate to severe bilateral compression. So we need to be careful about all of that. Andy, for neck rehab, should exercises that are aimed at causing, I got that. Yeah, so Andy, again, that's the same thread the needle thing that we talked about before. Julia Osborne, if you've been diagnosed with this, but also have CCI with a PICO procedure to treat both, or is it possible to have both? Is it one or the other? No, it's possible to have both, and really the initial focus is to treat the CCI. So if PICL is appropriate for you, that would be the next step, meaning that there's nothing about knowing that you have increased intracranial or that you have intracranial hypertension that really changes the treatment plan of trying to stabilize the neck. Kimberly, talking about brain fluid backup causing maybe pressure on the optic nerve. This is the owner of a company that had stem cell injection, owns many of the international patents. Has developed the process of stem cell replication and the treatments. Oh, okay. Not quite sure what that is. Gotcha. Duck B, have you read the study of a patient with chronic alar ligament injury start healing with hard collar usage for 3 months? I haven't. So if you could put that PubMed link in the comments, I'll be happy to review that. Again, you know, there's certainly patients out there who can heal their injury on their own, whether that's with chiropractic care, curve restoration, postural work, short-term use of a collar, all of that should be considered. And then obviously, if you get to that point and you're a couple months out and nothing's really changing or it's getting worse, then we're in a situation where other things need to be considered. But certainly be happy to review that. Jason, can you do a very quick recap of the many medical factors that affect a patient's optimal spacing between PICLs? I've heard fragile people say they're not ready even at 7 to 9 months. Can you speculate what exactly that might mean? Typically, tissue gets laid down and inflammation of PICL often goes away during the first month or two, right? Is a remodeling of the tissue at 6-month mark something different than 9-month mark? No, I think, Jason, what you're hearing is we have about 5% or about 1 in 20 of our PICL patients that I think you're describing them here as fragile. I would describe them here, I think I've called that type of patient a fragile egg to make it simple. It's really a centrally sensitized patient. So someone who has their central nervous system ramped up, and pretty much any treatment causes a flare-up. And PICL can cause a substantial flare-up. And those people, for example, wouldn't really be ready for a second treatment at the 3 to 4 month mark, which is what we're doing for the other 19 and 20 patients. They need longer to recover. With some of those, maybe some of those 5% may be stating, I need 9 months to recover before I get a second one. That's more the exception than the rule, but it does happen. I'm not quite so sure they're experiencing additional substantial remodeling between 6 months and 9 months, as much as it takes that long for the rare patient that we see for things to calm down before we would contemplate or they would contemplate a second procedure. Edward, is it possible that someone doesn't respond to BMC, responds to adipose stem cells? Unlikely, meaning given what we've seen with ligament healing and what's been published on ligament intended healing with bone marrow concentrate versus I think you'd be describing MFAT here, or microfragmented fat. BMC would tend to be better than adipose. So we wouldn't use adipose stem cells in this space for that reason, just because the existing research wouldn't suggest that it would be a superior treatment. Now, who knows? Maybe there's the rare patient that might respond better to one than the other, but no plans to begin using microfragmented fat at this point. And it would also require a much bigger needle to be used on my end, which would only up the risk for this procedure. Regenix submitted advanced by Harry Winston. Sorry to be off topic, but can a shoulder issue affect CCI? I injured my shoulder recently. It seems to make my CCI much worse. Sure, Harry, we see that all the time. So, realize that we've got the upper trap, for example. That's an easy one to think about, right? It goes into the top of the shoulder here, and it goes into the neck. So if you injured your shoulder and you're using your upper trap more, that's going to yank on the neck. And so we'll often see CCI patients with shoulder issues and vice versa. And in patients who can tolerate it, we're frequently treating shoulders with CCI just because we want to take that neck shoulder component out of the equation. Strange Velvet. Hi, Dr. C. This may have been asked before. Why are stem cells used to inject an alar and transverse ligament? Is there such a thing as using PRP instead? Also, I've heard of some folks having posterior injections using stem cells with the PICL protocol. What would warrant such a situation? Let's see. So we only use bone marrow concentrate to do PICL because in our extensive clinical experience, and in particular mine, there really isn't an advantage to using PRP over bone marrow, meaning bone marrow trumps PRP or is better than PRP in ligament healing. And then as far as getting posterior injections using bone marrow, almost all PICL patients get the anterior approach and the posterior approach at the same time. So for doing an anterior bone marrow procedure, we'll generally use the bone marrow for the posterior injection. So that's more common than not. Vivan, have you ever seen people with CCJ instability having changes of vision? It goes orange with a silent migraine with aura, but I have tons of facial tingling and posterior neck. We have what you're describing sounds more like a vascular migraine than craniocervical instability, but a lot of our CCI patients have difficulty reading, or they blow one pupil versus the other, and that's a sympathetically mediated problem, meaning this irritation of the sympathetic chain and or the superior cervical sympathetic ganglion, or they have a hard time coordinating their eyes for reading or smooth pursuit. So those are the kind of things we tend to see more: difficulty reading. I get dizzy when I walk down an aisle in the grocery store because I'm having to look left and right, and my eyes don't do that well. Or I've got blurry vision because I'm blowing my pupil, and that changes the accommodation, meaning changes how the lens works in the eye. Sarah, I had my first PICL on Wednesday and feel like I'm nearing my baseline. I know the post-procedural appointment for folks not until 4 months out. The curve restoration indicated for recent PICL patient, and they have to tolerate a rolled up towel under their neck. Then should the patient start reaching out to you about pursuing curve restoration? Yes, Sarah, so I would get to that point where you're completely at your normal baseline just to make sure that you can tolerate something like that. And yes, if you can tolerate a towel under your neck, I think it would be reasonable to try very gentle curve restoration, letting the provider know that you had this procedure on the neck, so they have to go very gently. Now, most CCI patients aren't going to tolerate that at this point, but some may. By then, IDOC said he didn't know if CCJ was causing it. Rotation of C0 to C1 on dynamic CT is 9 millimeters left and right. Yeah, so more than 8 millimeters on dynamic C0, C1 is going to be that type 1D rotational instability. So is it possible that that's linked to visual changes? It is. Lizzie, have you heard of distal radial ulnar joint instability? Is it worth treating? Sure. I've got distal radial ulnar instability in my right hand after a fall, as well as a TFCC tear. So we treated it with PRP pretty successful, I might add. I mean, at the time I was miserable. I don't really have any issues at this juncture. Jason, will the PICL be available outside of Colorado sometime in the next 5 to 30 years? Any idea of the general time frame, or where research is still in progress? Oh, sure, Jason. I mean, listen, I think that, as many people know, I'm in the last 3 to 5 years of my career. I don't really intend on working too much longer than that. You never know how things go, right? We could go into some sort of worldwide crisis and that changes. But right now, I'm not going to work past 3 to 5 years. And we have several doctors in the clinic that we've taught how to do this. But certainly when that gets closer to reality, when I'm cutting back more than I already am, and I've just cut back a little bit so far, I will begin sort of soliciting applications from people who I think are qualified to do this with additional education. And I will bring them out to Colorado, and I will begin training a select group of maybe 10 on how to do this. Now, it's going to take 2 to tango, right? Those doctors are going to have to give up a substantial amount of their time and income seeing patients in order to learn this and learn it well. So we'll get there. But, as I always say, we're still learning about this procedure. We're getting better and better at it year over year. We're now past the 1,000 procedure mark. And so we're getting into that, moving from, we started with how do you do this? And then we went to how do you do it well? And now we're in that phase of how do you do it with mastery? So once we get through that phase of how do you do this with mastery and get some publications out, we'll be ready to start that process. And that'll probably coincide with me pulling back even more than I have at this point. By then, any idea how pulsatile tinnitus is worse laying down and waking up in the AM? No known cause was found on the angiogram. Again, pulsatile tinnitus can be due to internal jugular vein compression. So if there is instability, it's possible that the laying down position is causing enough movement where you're getting a little bit of internal jugular vein compression. In addition, as far as waking up in the morning, a lot of people with chronic spinal pain and instability notice that their pain is worse in the morning. Why is their pain worse in the morning? Because the joints are a little bit swollen from overnight. So that could explain those symptoms. It's been advanced by Jerry Solinsky. Are there any treatments that work for vagus nerve issues that cause out of control inflammation, depression, and food intolerances? Well, Jerry, we certainly treat the vagus nerve in addition to the instability component if the vagus nerve is a major driver. So yes, there are treatments. Obviously, if it's instability that's causing the vagus nerve irritation, you treat the instability. The vagus nerve can be treated separately as well. And for us, that's usually with CCI treatment. By then, pulsatile tinnitus goes away with LP fluid withdrawal and pressure was 18 on opening. Yeah, so again, the pressure at the bottom of the fluid column from a lumbar puncture doesn't really say a lot about what's going on up here. In order to get intracranial pressure monitored, you need to float a catheter up to here, and that's almost never done in an ER setting. It's only done in a highly specialized setting in a few spots. Now, if the pulsatile tinnitus goes away with taking fluid out, then that would argue that it is intracranial hypertension that's causing it. And again, then you got to get into what's causing the intracranial hypertension. If it's CCI, then you treat the CCI and then see if it all goes away. But you got to get to that next step of saying what's causing the ICH. Jason, during bone marrow extraction, is an electric drill used? We certainly have electric drills. There's really not a need to use one for bone marrow extraction. Some of the doctors in our clinic like to use them, others not. It's not necessary. It doesn't really add much. It makes it a little bit easier physically on the doctor. So if the doctor isn't real strong, it can help the doctor. But, we're talking about not that much pressure that's needed to get through the bone in the pelvis. Now, for the doctors that use the inferior source of stem cells at the knee and the tibia, where there's only about half the number of stem cells that there are in the pelvis, then you've got to use an electric drill there. I don't know of anyone strong enough to get through that tibia bone, which is about 10 times thicker than the pelvic bone. So in that case, you have to use an electric drill. Usually that's an on-control device. So that's the name of the company that makes it, Arrow On Control. Jason, has any meaningful research been performed on the controllable environmental lifestyle factors that affect collagen synthesis and ligament healing? Not that much. I think there's a few studies on things like the effect of metabolic syndrome on ligament or tendon healing and collagen synthesis. But I think very few studies have been done on, let's take a group of people, try to change their behavior, and then look at collagen synthesis. Doug P, is there a neurosurgeon in Iowa that recommends immobilizing, or there is a neurosurgeon in Iowa that recommends immobilizing the neck for 6 to 12 weeks with a hard collar until upper cervical ligaments to tighten and shorten? Your thoughts on this? Yeah, it's a two-edged sword. I think if you had a difficult patient to treat who didn't seem to get better through direct injection, and you wanted to add another component, then that's something that could be added. But the problem is that it'll cause substantial weakness of the upper neck stabilizers that will be really hard to get back, and atrophy of those stabilizers. So it's 6 to 1, as my dad used to say, 6 to 1, half dozen the other, meaning that you're helping someone potentially on one side, but making them worse on the other. Specifically, I read a feeding study in animals, hogs, in which they fed them very, very well. But when they gave them sulfur, they had 20% more collagen in their tissue than the control group. Have you ever heard of something similar in humans? I haven't. Doesn't mean there isn't anything, but I haven't seen it if there is. Doc P, have you talked to neurosurgeons about PICL? What do they think of it? Not really talked to many neurosurgeons about it directly. We certainly know that many of the surgeons that do a lot of work in this space know about the procedure, and many of them are pretty open to it. They're like, yeah, sure, give that a shot. If it doesn't work, come back and see me. Andy, I'm guessing the physicians you will train to perform PICL are highly skilled in performing C0 and C1, C2. Yeah, I mean, one group is clearly going to be my former fellows, and that's an ever-expanding group. Another would be physicians who do a lot of 0-1 and 1-2. The biggest problem is not only technical, which is substantial, but there's also the component of needing to buy new equipment, which is something these days that a lot of doctors aren't really keen on. And finally, there's understanding this patient population, which is not easy to do. Meaning that this is a patient population with a lot of unique needs, and that takes a lot more energy to treat than many of the other kind of patients that they're used to seeing. So all of those things have to fit in order to be taught how to do this. Ulysses, how do we get distal radial ulnar instability? How do people get it? Weightlifting a part of it. Yeah, weightlifting can be part of it, but usually it's a fall. Mine was a fall. I hilariously had those little shoes that have the not laces, but the little cord that you tighten. And when they sell them, they don't tell you you're supposed to tuck that little thing in there. And so I hadn't tucked it in. Both of my shoes cord things got locked, and it was like someone lassoed me, and I fell on this hand. And I wasn't severely injured, but I had severe pain in this wrist for 6 weeks, and then we started hitting with PRP, and eventually it got to be no big deal. I don't even wear a tape. I don't even wear tape anymore when I lift weights, but I did for the first year or two afterwards. Lindsay, 1.5 weeks out from PICL and having bulging disc treated. Since my procedure, my right arm is killing me. Feels like a nervous pinch. Did you have this before the procedure? Any idea what is causing this? I'm not sure, or maybe did not have this before the procedure. Any idea what's causing this? Yeah, Lindsay, I would need to know more specifically about what was done to treat the bulging disc. If you just want to reach out to your clinic physician and ask that directly, that's probably the best way to go there. Jason, I noticed after a PICL, I suddenly gained control over a bunch of small muscles in the back of my head and neck area. I find that I can rotate my skull and halt neuro symptoms by actuating those muscles. Can you speculate on why this might be? Yeah, so Jason, what tends to happen there is, or at least we believe what happens, is that the instability causes the muscles paradoxically to shut down, and then gaining some stability from the initial swelling period, what we would call honeymoon, can cause those muscles to reactivate. Now, those muscles are responsible for half of all the stability, so getting them back online could be a major functional gain. Another thing that could well have happened is the same thing with the facet joints. When the facet joints are painful, those muscles shut down. By treating the facet joints with something like high-dose PRP, we may have made the facet joints feel better, and all of a sudden the muscles start working again. Amen. I think I got it right. Amen. Dr. Centeno, I have an AI, 27 years old. He's just having fusion surgery, and it's more accessible right now. Just wait till I manage to get the PICL. Yeah, amen. I think the best thing to do would be to do a telemedicine appointment and try to sort all of that out. That's probably the next best step. Okay, guys, any other questions for me? We were talking today about the relatively complex topic of ultrasounding the optic nerve. And while it's an interesting concept, and we're happy to give you your optic nerve sheath diameter in the clinic, the question is, what do we do with that information, and how does it change the treatment plan? Any other questions that I can answer that anyone has out there, happy to answer. With moderate IH, AT, and LP, what does exercise make pulsatile sound worse? And does exercise worsen IH pressure if the sound increases in intensity? Can exercise cause worse pressure? Well, when you exercise, obviously you're increasing the blood flow to the brain. And if there's a problem with getting blood out of the brain, that could increase the pressure inside. In addition, just realize that all of the blood goes back and forth. So artery, vein, and that activity is going to increase during exercise. So it might have nothing to do with pressure and everything to do with the heart rate being increased. So that would make any pulsatile tinnitus louder and faster. Jason, I noticed hip pain 3 months ago at BMA. Is it likely related? I don't know what you mean by that one, Jason. I noticed hip pain 3 months ago. So or 3 months after BMA is likely related. Unlikely related to the BMA if it's 3 months out. Felix, have you heard of patients with CCI improving with peptides like BPC 157 or others? I haven't really heard of BPC 157 dramatically improving CCI. Based on the existing published data, the real stuff that they use in the research lab, not the stuff you can buy online, works about as well as PRP works in stimulating things like tendon cells. So I don't know. For me, I wouldn't buy BPC 157 online because I can't be certain about what I would get back from someplace where I ordered it. Andy, can you recommend any names of your foreign fellows who are good with this? I joined instability injections. Sure, all of them should know how to do that. If you reach out to Carla, she can give you a name or the names of the fellows. There's lots of them out there, but all of them should do well with that. Krishna, is this increased optic nerve sheath diameter and ICH reversible? Yeah, Krishna, that's the general idea. If it's due to CCI, then the game plan is treat the CCI. Ulysses, what's the next video you were doing on Friday? I don't know, Ulysses. I may get to your needle diameter thing, but I don't have any game plan. Probably won't game plan it out until Wednesday or Thursday. Edward, could you briefly summarize why there are so many clinics claiming that adipose stem cells are superior or newer than BMC? Sure, I've done this a number of times, but it actually might be a good time to do a blog on it and really dive into it. So first thing we have to do is to unpack this, is to break it down into what we mean by, quote, adipose stem cells. Used to be that meant adipose stromal fraction. That's when you took fat, you digested away the collagen, and then you centrifuged out a stem cell sample fraction, just like bone marrow. But in bone marrow, we don't digest any collagen. Now, the FDA came in and said that if you digest the collagen, that's illegal. They don't like that. That makes it an unapproved drug. So that has kind of gone out of favor in clinics. And instead, what clinics are doing now is they're using microfragmented fat, or what we call MFAT. Microfragmented fat just means we take fat and we break it up in some little device. There's lots of little devices out there to do it. And you're really just injecting a very finely chopped up fat graft. So it's not really a stem cell procedure per se, because there are very few free stem cells. The stem cells are locked in their collagen prisons. But that's usually what we're talking about. In an MFAT procedure, there are fewer available stem cells than there are in a bone marrow concentrate procedure. In a stromal vascular fraction procedure, which is the illegal one, there are usually more mesenchymal stem cells, but fewer hematopoietic stem cells and fewer other cells like macrophages. When it comes to head-to-head clinical trials so far, between for things like knee osteoarthritis, bone marrow and adipose seem to work about the same if we're talking about MFAT there. And then when it comes to ligament and tendon healing, bone marrow seems to do better than MFAT. So that's the 30,000 foot view discussion on both, but it's probably time for me to do another longer blog on that. In fact, I'm going to, since I'm getting old here, I got to remind myself here. So I'm going to send myself a quick reminder on that, because that's a really good topic for next week's blog. Okay, just need to remind myself, because that's a good one. Krishna, are floating no vision a symptom of ICH? Not usually, but again, those things can be associated with very high blood pressure, for example. And one mechanism there could be ICH. Sarah, is it fairly common, typical for patients to have increased symptoms in the low back after having a PICL, assuming there's already instability there? Not super common. I think what we tend to see more commonly is as people get better up here, they start to sort of focus on the other problems that they have had. And that's a common thing we see. Amen. Is it true that a mild disc bulge at 5'6" can be treated just with physical therapy and resting? True, the body will heal from it naturally. Well, I think it's true to say that most mild disc bulges don't require surgery or much treatment at all. Physical therapy tends to work pretty well for most people. 5N, how do you find anyone who will do CCI, BDI ankles, etc., the CCA junction? Mine have never been measured, and I have significant CCG abnormalities, a curvature of 23 degrees. Do you do this? Yes, the Bayesian-Dens interval usually isn't expressed as an angle. I think you might be thinking of something like a clivo-axial angle. But yeah, we measure all of that in a telemedicine, or at least all of that looks appropriate and specific to the person. Okay, guys, I think we're coming up on 1 hour. Any other questions I can answer? Just to sort of summarize what we talked about today. We talked about the whole concept of using ultrasound to measure the optic nerve sheath, and as such to determine whether or not there's intracranial hypertension. And just ultimately concluded that we don't have much research in CCI patients or similar patients that this is a helpful measurement, but we're happy to measure it for people if they want to see it. We're not going to charge anything extra to do that because it takes all of 10 or 20 seconds to do. And then the question becomes, what do you do with that information? And then how do you actually act on that? Let's see, VLOX, do you recommend other doctors in different states treat CCI? The Regenetics doctor is the best to see where I am locally. No, yeah, I really don't. This is such a highly specialized area. The only place we focus on CCI is in Colorado. As far as Regenetics doctors, they don't specialize in CCI, so that's a Colorado only thing. Jason, why do some people develop compensatory veins more than others? I think you mean collaterals. A lot of that is a combination of genetics, overall health and activity. We know, for example, that in the legs, you can develop more collaterals by just walking versus someone who's sedentary. So those are some of the concepts there. Okay, guys, I want to thank you for your time today. We're coming up on an hour. I will be here this Friday with a new topic, and thanks for all your great questions. There are no bad questions here. There's only not getting answers. And if you've got the answers and you keep getting the answers, you'll learn. And educated patients, in my experience, always get better quicker than those who aren't. So thanks so much for watching, and thanks for getting educated.